There are many things to be aware of in managing surgical patients before and after surgery. This brief presentation focuses on anesthesiology-related issues. I thought about making this video funny. Even though sometimes laughing gas is used in the operating room, managing surgical patients is no laughing matter. This is the schematic of the process for those surgical cases where the patient goes to primary children's hospital and come back to our unit for recovery. Step 1, pre-op. What are the patient's risk factors do you want the anesthesiologist to know? FE and GI. Does the patient have bad gastric reflux that increase the risk of aspiration? Liver failure can decrease hepatic clearance and may prolong duration of anesthetic medication effect. If the patient is on diuretic, the patient may have electrical abnormalities or intravascular depletion. Renal failure can also decrease anesthetic drug clearance. Respiratory. Does the patient have a history of prolonged mechanical ventilation, which may make it hard to be extubated, and there's an increased risk of bronchospasm, apnea, and reactive airway diseases. Pulmonary hypertension can cause pulmonary hypertensive crisis and hypoxia in a time of stress. Does the patient have difficult airway issue and history of multiple intubation attempts? Cardiovascular. Congenital heart disease can increase the risk of hypoxia and cardiovascular instability. Hypertension may worsen with inotropes and pain. Neurologically, seizure disorders is important to be aware of because some anesthetic medication like ketamine can lower seizure threshold. Does the patient have suspected neuromuscular diseases or hypertonia which can cause poor respiratory effort? On the flip side, hypertonia can cause the jaw to be really tight and difficult for people to intubate. Prematurity can increase the risk of post-operative apnea, and you want to avoid oxygen toxicity due to the risk of ROP. Blood disorder can increase the risk of excessive bleeding or clots. Does the patient have a history of adrenal insufficiency, which can lead to adrenal crisis in the time of stress? Does the patient have any congenital anomalies and facial or airways abnormalities? Skin fragilities or sensitivity can cause skin breakdown from tape irritation or any major medical problems that you want the team to be aware of. How to mitigate and communicate all these risk factors by providing a last progress note and an all HMP note to the anesthesiology team. Highlight key points as needed. What? You can't remember all the risk factors to communicate? Don't worry. The AMA pre-op checklist may help to highlight all these key points to the anesthesiologist team. After the pre-op check and hands-off, the anesthesiology team will prepare the baby for anesthesia induction. There are two ways of induction: inhalation and IV. Inhalation induction. Inhale gas. Baby breathe through a mask with anesthetic gas. Is fast onset, ready for intubation in 60 to 90 seconds. It's great for induction if the baby has no IV. The choice of gas includes sevoflurane, which is most commonly used, rapid onset, less pungent smell, is less likely to be associated with laryngospasm and bronchospasm. Nitric oxide, which is also known as laughing gas, can induce unconsciousness, but it is not potent enough to allow airway manipulation when used as a sole agent. It is usually used with other inhale agent. It is turned on for induction, then turned off after intubation, which will be well cleared at the end of the surgery. It's not used at all if the patient is under IV induction and not used by all anesthesiologists. inhalation gas may cause dose-dependent vasodilatation. Intravenous induction. IV medication is a good way for induction if the patient already has an IV. Most NICU patients do. Rapid sequence intubation medication include propofol 3 mg per kilo, fentanyl 1.2 mics per kilo, vacuronium 0.2 mg per kilo, or rocuronium 1.2 mg per kilo. Atropine 0.02 mg per kilo IV can prevent bradycardia. Propofol may cause pain during infusion, so lidocaine or fentanyl may be given at the same time. Neonates may need higher propofol dose due to drug distribution. After induction, there will be the maintenance phase, which include 3 areas: sedation, analgesia, and paralysis. Sedation, blunt consciousness. Medication used for sedation include inhalation gas, sevoflurane, isoflurane, and desiflurane. We already talked about sevoflurane earlier. Isoflurane is the cheapest gas but have really bad smell, slower onset, and increase in laryngeal spasm and coughing. Desiflurane is rarely used in neonates as the fastest onset is good for obese patients. These inhaled gas doses and concentration are titrated during the procedure. Other medications include propofol, which has a quick on and off onset of drug effect. Versed is a short acting, which we are very familiar with. Precedex provides both sedation and analgesia while preserving respiratory drive. Ketamine is useful in hypotensive patients due to minimal effect on blood pressure. It may cause excessive secretion, so you can give atropine or robenal to decrease secretion. It can also cause hallucination, and sometimes benzodiazepine is given to blunt that effect. Analgesia decrease pain. The medication includes fentanyl, short half-life, single dose can last about 30 minutes. Repeated doses of drip increase medication effect duration. High-dose opioid can also have sedation effect. Other medications include Dilaudid, Tylenol, Toradol, local anesthetic, and NSAID, but generally which is contraindicated in neonates. Paralysis, muscle relaxant. It's given at a lower dose than the induction dose during the surgery. Vacuronium 0.1 to 0.2 mg per kilo or rocuronium 0.6 to 1.2 mg per kilo. Trainer 4 peripheral nerve stimulator is sometimes used by the anesthesiologist. They stimulate the superficial nerves on the baby's face and count eye twitching. 1 to 4 count indicate partially paralyzed, and the patient may need additional dose of paralytic medication. 0 count, no twitch, means patient is fully paralyzed. Single dose doesn't last very long, and liver and kidney failure can delay drug clearance. As the case is finishing, it goes into emergent and reversal. Emergent. The goal is to achieve a smooth control emergent from anesthesia, avoid laryngeal spasm, bronchospasm, oxygen desaturation, cough, and vomiting. They turn the inhalation gas off, sedation effect wears off, and they breathe off within 10 minutes. Reversal refers to reversing the muscle relaxing agent or the paralytic agent. Sugammadex is used to reverse the effect of the muscle relaxant, example, rocuronium and vacuronium. Doses between 2 to 16 mg per kilo. If only 1 dose of rock is given, Sugammadex 16 mg per kilo can reverse right away. If the last dose of muscle relaxant had been given for a while, like an hour, and 1 twit on the trainer 4 monitor, then 2 mg per kilo is sufficient. Opioid effect is never reversed. The reversal agent is Narcan. Benzodiazepine effect is also never reversed. And then reversal agent is fumacenol. Extubation. Endotracheal tube can be removed once the patient is fully awake. Endotracheal tube should not be removed during the excitement or delirium stage as the patient emerges from anesthesia. It may induce vomiting or laryngeal spasm. There are 4 stages of anesthesia. Stage 1, analgesia. Stage 2, excitement. Stage 3, surgical anesthesia. Stage 4, medullary depression. Patient goes from being awake to stage 1 to 3 as the anesthesia deepens. After surgery is complete, patient slowly recovers from anesthesia, going from stage 3 back to stage 1. And you don't want your patient to go to stage 4, so we're not going to go there or talk about it. Stage 1, analgesia or disorientation, aka induction stage. This stage is when the patient is given medication and may begin to feel its effect but still conscious. Breathing is slow and regular, starting to have analgesia with amnesia. This stage comes to an end with the loss of consciousness. Stage 2, excitement or delirium. This stage is marked by features such as disinhibition, delirium, uncontrolled movement, loss of eyelash reflex, hypertension, and tachycardia. Airway reflux remain intact during this phase and are often hypersensitive to stimulation. Airway manipulation during this stage of anesthesia should be avoided, including both the placement and removal of endotracheal tubes and deep suction maneuver. There is a higher risk of laryngeal spasm at this stage, which may be aggravated by any airway manipulation. Consequently, the combination of spastic movement, vomiting, and rapid and irregular respiratory rate can compromise the patient's airway. Fast-acting agents help to reduce the time spent in stage 2 as much as possible and facilitate entering into stage 3. Stage 3 is surgical anesthesia, a targeted anesthetic level for procedures requiring general anesthesia. The patient will cease eye movement and respiratory depression are the hallmark of this stage. Airway manipulation is safe at this level unless it's a neonate that depends on respiratory drive for extubation. After the completing a case, and then there's the transfer back to the unit. Communication is key. Sign-out report. 3-way phone call with anesthesiologist, transport team, and NMP fellow attending should be performed. Transport across the bridge can take up to 15 to 20 minutes. Ask appropriate questions to the anesthesiologist or self. Is the patient well sedated or too awake for transport? Will the patient be too excited and at risk of self-extubation during transport? What is the last dose of medication given? How long will it last? Does the patient need another dose of opioids, Tylenol, or benzo for transport? If the muscle relaxant reversed, it is mean to paralyze but not sedated. And how to avoid over or under ventilation during transport. Post-op management. More questions to self and NICU staff. Pain and sedation. Is the NICU bedside nurse ready for any sedation and pain medication before patient arrives? Does the bedside nurse know the ETA of the patient? If muscle relaxation is not reversed, how long will it last? Would it affect gut motility? Is this patient opiate naive? A non-opiate naive patient may need more pain medication. Does this patient have liver or renal failure that prolong drug effect? Respiratory. Is respiratory support and respiratory therapist ready for the baby upon arrival? Prematurity increased risk of apnea. A retrospective study showed that 9% of the NICU patients will have major post-operative respiratory events. The risk decreased with increasing postmenstrual age. Apnea can occur up to 12 hours after surgery, so don't let your guard down. Does this patient have severe lung diseases or other comorbidity that would compromise respiratory status? If you can't remember all that, the MA post-op hands-up report will be extremely helpful. Upon the patient arrival, post-op recovery should be done in room 1 or 2. Communication is the key. Try to stop and listen to the transport team sign out because they may have really important information to share. Pain control. The patient may still be in pain. Moving from the transport incubator to the bed may be painful. Please ensure adequate pain control. Minimal stimulation. It still hurts, so limit number of providers that do physical exam or delay any unnecessary blood draw until the pain is adequately controlled. If muscle relaxant is not reversed, the patient would not be able to show pain. Temperature. Hypothermia may delay metabolism and excretion of anesthetic agent and can potentiate neuromuscular blockage. So keep the patient warm. Vital signs. Please check it every 15 minutes times 4, then every 16 minutes times 4, and every 2 to 3 hours till the patient is stable. Please provide respiratory support as indicated and extubate when the patient is fully awake but not in the excited or delirium stage. Last but not least, there's a rare complication called malignant hypothermia. It is an inherent disorder that is triggered by the inhaled anesthetic agent N-acetylcholine. It usually occurs within the first 2 hours of anesthesia but can occur up to 24 hours later. It can be fatal. The signs include a rapid high fever, 38.5 to 46 degrees Celsius, increasing 1 degree every 5 minutes, muscle rigidity, acidosis, or cardiac arrhythmia. The treatment include correct acidosis and IV dantrolene. Thank you for listening.